Good morning, good morning, good morning, and welcome to another educational session brought to you by your Department of Continuing Medical Education. We are so happy that you can join us for our first CME activity for the month of April. Before we get started, let us have a word of prayer. Father God in heaven, we thank you so much for allowing us to be here to see another day. We ask you to open our minds to receive the information that our speaker would present to us. We pray that we can use this information to help our patients and to make a difference in their lives. This we pray in Jesus' name. Amen. This morning, we are excited to welcome Dr. Dalecia Bodie, who will be presenting to us today. Dr. Bodie completed her Bachelor's of Medicine and Bachelor's of Surgery at the University of the West Indies School of Clinical Medicine and Research, the Bahamas, in 2014. She went on to further her education, completing the Doctor of Medicine in General Surgery program through the University of the West Indies Ona, Bahamas campus in June 2023 and became the first female to do so. She has future career plans to pursue a specialty fellowship in minimally invasive surgery. Currently, she practices as a senior registrar in general surgery at the Princess Margaret Hospital. Please welcome Dr. Dalecia Bodie as she will be presenting to us this morning on the approach to the patient with an acute abdomen. Dr. Bodie?
A pleasant good morning to all. Just confirming that you can see my slide and you can hear me.
Yes, we can.
Okay, great. Thank you for allowing me to present at CME this morning, and I would like to present a topic. It's a bit complex, but I thought was very timely in our day-to-day practice, as not just us as surgeons encounter the patient with the acute abdomen, but most times it's usually referral through either the emergency room or from the clinics. For patients who may have presented through those areas. So this talk I gave earlier this year at our departmental grand rounds, and I've tailored it a bit for the non-surgeon physician. For the purposes of this talk, we will, of course, go over the definition and the more common causes of an acute abdomen, looking at the incidence, etiopathophysiciology, clinical presentation, investigations, diagnosis, the immediate management for non-surgeon physicians, and when to refer or consult the surgeon for these patients who present. So an acute abdomen is defined as the sudden onset or sudden abdominal pain that's severe enough to cause a patient to present to hospital, usually within a 24-hour of its onset, and may or may not require surgical intervention. If we remember from medical school, the causes of acute abdomen include inflammation, perforation, obstruction, rupture, ischemia, and trauma. However, for this presentation, we will only go over the common causes of the first three listed on the slide. Just as in real estate, we have to remember location, location, location is most important when a patient presents with an acute abdomen. As you can see, the differentials are many, and we need to try and tailor or think about what the possible cause is based on the location of the patient's abdominal pain. And that brings us to the point or the consideration that we must have but always in the back of our mind, that not every acute abdomen is a surgical abdomen. So we will start with the first cause, acute appendicitis, which everyone I'm sure has encountered at some point, either personally or referred a patient or had a patient diagnosed with acute appendicitis. And it's simply referred to as the inflammation of the appendix. International statistics show that it commonly affects patients within the 15 to 29-year-old age group. Unfortunately, I do not have our local statistics, but I'm sure most of us would agree we do see it in that population, and then we may have an outlier older population or even younger population that we must always keep or consider, as they usually have a very different presentation from the typical or that of the norm. The appendix, we know, or its base can be found at the tinea coli on the cecum, and it has various positions that you can see in the second or the middle diagram. In terms of its pathophysiology, it starts based on a simple obstruction, where that be from a fecal adhesion or lymphoid tissue that causes obstruction of the appendiceal lumen. And the appendix, yes, does have some residual function in terms of producing mucus, as it's still lined by the normal epithelium of the rest of the colon, and it does serve as a reservoir for bacteria. And so in the presence of obstruction, the mucus and bacteria continue to proliferate, increasing the intraluminal pressure, and that in turn leads to a lot of major consequences at the level of the capillary bed, including lymphatic obstruction, venous obstruction, leading to arterial compromise, which later affects the actual mucosa and the lining or the wall of the appendix, leading to ulceration, ischemia, gangrene, and perforation. And we'd like to try and identify these patients before the latter occur, which can lead to dire consequences. So typically, patients would present with the text, or can present with the textbook history of periumbilical pain that migrates to the right lower quadrant, usually presenting with nausea and vomiting after the onset of pain. They may have anorexia, fever, and/or chills. And we have to remember that subset of patient who may have a late presentation, or who may present after perforating and actually present with simple signs of bowel obstruction. And so anytime you have that patient who is just not presenting as a typical bowel obstruction and has that abnormal or that not common pain, we must always consider the possibility of acute appendicitis. And of course, because of any of its various locations, usually the pelvic type of appendicitis can rest on the urinary bladder and present with urinary symptomatology. Most importantly, we must always ascertain a gynecologic and sexual history, particularly in our female patients, as based on the appendix having a pelvic location, can present similarly to patients with pelvic inflammatory disease. When examining patients suspected to have an acute appendicitis and any other patient, it's always important to first assess the patient's vitals and their general appearance. On examination, we may elicit the typical signs of McBurney's point tenderness, which is 1/3 the distance from ASIS to the umbilicus. And there may be some other signs, such as Robson-Soas and obturator signs, that we may want to elicit that simply speak to the position of the appendix at the time of presentation. Again, we may have those patients who may present in the extreme cases or delayed cases, who would present with generalized peritonitis due to perforation. As mentioned before, the gynecologic history and examination is always important, so the examination should always be completed with a vaginal examination assessing for vaginal discharge and cervical motion tenderness to exclude the possibility of gynecologic pathology, namely pelvic inflammatory disease. Appendicitis remains a clinical diagnosis, and so investigations are done simply to confirm your suspicion, get an objective confirmation of your suspicion of appendicitis. And so the complete blood count electrolyte panel should be done, and of course the serum beta ACG for patients of women of childbearing age, to make sure it's not other gynecologic pathology such as an ectopic pregnancy. A right to lower quadrant and pelvic ultrasound can objectively give us findings of an acute appendicitis, and also can exclude it and rule out other gynecologic pathology. CT abdomen is not necessary for the diagnosis of appendicitis. However, we may have patients who present with a diagnostic dilemma, or the appendix may not be visualized on ultrasound. There may be complex or multiple pathologies that are seen on pelvic ultrasound, or just based on the user dependency of it. In those cases, a CT abdomen may be warranted for us to have more objective determination as to what exactly is the cause of this patient's acute abdomen. So on the pelvic or right lower quadrant ultrasound, there are certain key findings that we look for on the report or verbal confirmation from our radiologist. And usually we would see words such as a non-compressible blind ending tubular structure. Usually the cutoff that we look for in terms of the dimensions are 6 millimeter in terms of size, with periappendiceal fat stranding or fluid. McBurney's point probe tenderness also is very specific for the diagnosis of acute appendicitis. And of course, we want to make sure that other organs within the pelvis are without any pathology and are normal, to exclude those as possible diagnoses in this patient. This slide here just shows, sorry, it's a bit blurred in terms of CT findings of acute appendicitis. So if you are still waiting on the CT report, you can scroll through and peruse your CT to look for the findings of appendicitis, such as dilation. You may see fluid within and fluid around the appendix, and you may even see an appendicolith within the lumen or causing the obstruction of the lumen of the appendix. There are certain adjuncts we can use and simple calculators. This is from MedCalc that we use to help us in terms of validating or determining the likely probability of appendicitis. And of course, you just plug in the patient's symptomatology within the calculator and using the Mantrels. We look at scores that are 7 and above that are more likely appendicitis to have that actual diagnosis or make that diagnosis of appendicitis. So what do we do when we have all of this information? Of course, prior to referral, we have our strong suspicion or we have our confirmed radiologic diagnosis of appendicitis, and even based on our history. We want to make sure that there is a documented history, physical exam. We have our baseline lab investigations, imaging, and to initiate in these patients resuscitation and give them IV antibiotics, as we know more than likely these are patients who will need surgical intervention. And when exactly do we refer or consult? Immediately once that checklist is done. Do not delay any referral of these patients, even if you have a strong suspicion prior to awaiting your official imaging or a CT report. Remember, acute appendicitis still remains a clinical diagnosis, so we should urgently refer these patients, as the complications of acute appendicitis can be very dire for these patients, and we want to prevent any major complications or morbidity and even mortality in these patients. So the next cause of acute abdomen is acute cholecystitis, which is another common diagnosis that we encounter almost on a daily basis. And again, it's simply the inflammation of the gallbladder. Traditionally or historically, we've been taught that who gets appendicitis, the typical patient is the fat, fertile female in her 40s who is flatulent and fair-skinned. And we have to remember that we do live in an Afro-Caribbean society, and so our patient is not always going to be of the fairer skin complexion, but we do have darker skin complexion patients just based on our makeup, our skin pigmentation and color. And also based on where we live in the Afro-Caribbean or in the Caribbean, we do have that atypical patient or that patient who has increased risk for complications of gallstones, which is our sickle cell population. And so we should always consider these patients when someone presents with the typical history and examination findings of acute cholecystitis. So its pathophysiology is similar to that of acute appendicitis, but it starts, of course, because of what constitutes a gallstone, and in terms of the loss of equilibrium in the balance between cholesterol, bile salts, and phospholipids. And commonly in the Bahamian population, it's due to too much cholesterol or too much fat in the diet. And of course, in our sickle cell population, because of their hemolysis, they have a lot of bile and usually present with bile or pigmented stones in their pathophysiology. It's important to remember, because of the pathophysiology of acute cholecystitis, it is not the same as symptomatic cholelithiasis, where patients typically do not have obstruction of the gallbladder lumen. They don't typically get that edema, that gross inflammation that can lead to complications of ischemia and even perforation or gangrenous gallbladder. And so these patients are the ones that should be properly assessed to differentiate symptomatic cholelithiasis versus an acute cholecystitis that often warrants surgical intervention. The history is typical of a patient who presents with nausea and or vomiting following right upper quadrant pain or epigastric pain, and is typically after ingestion of a fatty meal. And sometimes that ingestion may not be immediate or before their presentation. It may be the night before. Usually their last meal is usually a fatty meal. And of course, in our population is usually after the conch, lobster, crab and rice, the Christmas ham, pig feet sauce, bamboo shack, fried fish, chicken, etc. And so we must also ask the patient specifically, what was the last thing that you ate? Because they may not always relate it to their diet. Patients may present with complications of acute cholecystitis or severe cases of cholecystitis where they present with fever, chills, jaundice, pruritus, confusion, or altered mental status. And if you remember from medical school, that may be encompassing either Charcot's triad or Reynolds pentad. And it's important to identify these patients, as these are the patients that we need to adequately manage to prevent complications of morbidity and mortality. And they often require more urgent surgical intervention. Again, when assessing patients, always start with the vitals and their general appearance, as that tells us how ill a patient may be and how urgently they need to be referred to the surgeon for intervention. Examination findings may elicit the Murphy's sign, which is usually the arrest of respiration on palpation of the right upper quadrant due to an inflamed gallbladder. Patients may have in absence of Murphy's sign, there's right upper quadrant tenderness that may radiate along the flank and to the right lower quadrant, and that usually signifies either a lot of fluid related to the pericholecystic fluid or even perforation of the gallbladder. They may have epigastric tenderness depending on how dilated the gallbladder is, or inflammation and irritation of the liver, or generalized peritonitis from pre-perforation. It's always important to assess a patient from head to toe, including the respiratory examination, ensuring that there are not signs of a pneumonia, right lower lobe pneumonia in these patients. So assessing for decreased lung sounds, dullness on percussion, to make sure that this patient may not be presenting with a pneumonia. The investigations, again, are done to confirm our likely suspicion of our suspected cholecystitis, and of course, beginning with our complete blood count, electrolyte panel, CRP if available, and liver function test. Coagulation profile and blood gas is not necessary to make a diagnosis. However, it does help us in determining the severity of patients with acute cholecystitis. So typically, once the patient is referred, you may see us in terms of the surgical body requesting these things to try and stratify or risk stratify this patient into mild, moderate, or severe acute cholecystitis as their management differs. A right upper quadrant ultrasound is important in identifying or diagnosing a patient with acute cholecystitis, and we'll talk about those signs on imaging. And in rare cases, patients are imaged with a CT abdomen. Usually if there may be somehow a diagnostic dilemma, or there may, for whatever reason, be bowel overshadowing, or rare cases, if the radiologist not able to visualize the gallbladder for whatever reason, that we get a CT abdomen. And if thinking possible complications of acute cholecystitis. But the typical findings on ultrasound, of course, includes the presence of gallstones, which ultrasound is more specific and sensitive for compared to a CT. A sonographic Murphy sign, gallbladder wall thickening that's usually more than 3 millimeters, and pericholecystic fluid. So these are the things that we look for in the report that tell us that this patient has an acute cholecystitis, opposed to the simple presence of stones within the gallbladder, and in absence of the other findings, which is just cholelithiasis or biliary colic. This here is a CT that shows the evidence of acute cholecystitis. You see a very well distended gallbladder with pericholecystic fluid, fat stranding, wall thickening. So there are certain guidelines that we use, or tools that we use, again, to help us make the diagnosis. And we use the Tokyo guidelines, 2018 Tokyo guidelines, to help us in making the diagnosis of acute cholecystitis, whether it be suspected, that is having one item in A and one in B, which is local and systemic signs, or definite diagnosis of acute cholecystitis, that is having one item in A, one item in B and C. So local, systemic, and imaging findings characteristic of acute cholecystitis. So again, once you have all of this information together, you perform your checklist, making sure your history, physical examination is complete, your baseline investigations are done, your imaging. And of course, you know, this patient likely is going to need surgical intervention. So initiating that resuscitation and IV antibiotics for this patient is going to be most helpful in terms of their outcome. And when do we refer and consult? Again, immediately after that checklist is complete. Do not delay your referral for these patients. Often we trivialize the patient who has issues of gallstones. We say it's not an emergency. These patients can have very severe complications of acute cholecystitis. It is a surgical urgency and sometimes a surgical emergency, depending on the severity of the disease. This then brings us to our next cause of acute abdomen, which is acute pancreatitis. And we remember acute pancreatitis as the others from medical school is inflammation of the appendix that results in the temporary loss of exocrine function and autoimmune destruction of the pancreatic parenchyma. And who gets it? Usually the male who has the ETOH binge, the female with gallstones, adult female with gallstones, or the child who has had some recent trauma to the abdomen and is usually or historically taught as a handle bike injury to the epigastrium. So these are the typical three demographics of patients who present with an acute appendicitis. In its pathophysiology, of course, because of one of the three inciting incidents, there's usually some cause of obstruction to either the pancreatic duct from either the stones, either autoimmune that may cause release of the enzymes that cause autodestruction of the pancreas and set off that inflammatory cascade that causes the patient to present to hospital. So it's important that we ascertain the history from the patient specific to their demographic, inquiring about ETOH misuse or binging, inquiring about their dietary habits, known history of cholelithiasis, and in children, of course, because they're active, inquiring about trauma, whether there be accidental or intentional, to exclude or when we're entertaining the diagnosis of acute pancreatitis. And of course, the patient who has a history of hypercholesterolemia. We should also inquire about the different characteristics of this pain, whether there's a radiation to the epigastrium, radiation to the back, nausea and vomiting, fever, chills, and jaundice in the more severe patient. And of course, we remember the mnemonic, I get smashed, from medical school, that tells us the list of possible causes of the acute pancreatitis that we should always inquire about. Again, when examining patients, start with the vitals and their general appearance. That always tells us the severity or how ill a patient is and how urgent we need to refer these patients. On examination, we may elicit epigastric tenderness. We may see signs that are suggestive of hemorrhagic pancreatitis, such as Cullen's, Gray Turner, or Fox's sign. And some patients may actually present with generalized peritonitis just based on the severity or how ill their pancreatitis is. They may sometimes even present with ascites, and these are the extreme patients. As mentioned before, head-to-toe examination is important, and in these patients, respiratory findings suggestive of pleural effusions is very important and significant, as this is typically the more severe, more ill patient who usually requires ICU admission and surgical intervention. So our investigations, we always start with our blood investigations, our complete blood count electrolyte panel, and the serum amylase and lipase, which 2 to 3 times that of the upper limit is diagnostic for patients with acute appendicitis. Liver function tests, coags, and blood gases, again, are not mandatory for the diagnosis, but they speak to the severity of disease. So we usually add these on to determine if a patient may have evidence of organ dysfunction, which is usually the more severe spectrum of disease. Our baseline right upper quadrant we usually have done for these patients once they're diagnosed or once they're admitted, to exclude the possibility of gallstone pancreatitis, especially in a patient who is known, or if it's a female who presents with a history that started with right upper quadrant pain. We want to exclude the presence of gallstones. And further imaging of a CT is not indicated as a baseline investigation, but is usually done only in suspicion of complications of pancreatitis, and is usually pancreatic necrosis or infected collections that we suspect. And if the patient typically doesn't resolve in the usual 48 to 72 hour timeline. So these are CT findings of acute pancreatitis. So if it is the patient presents very ill and we have suspicion of complications, whether it's pancreatic necrosis, fluid collections, or pseudocyst, these are the various findings that we may see when performing a CT of these patients. Otherwise, generalized edematous pancreas, peripancreatic fat stranding, peripancreatic fluid. These are the typical signs of inflammation as for acute appendicitis or cholecystitis that we would see on ultrasound of these patients that suggest acute pancreatitis. So based on the revised Atlanta 2012 classification, and it hasn't changed, the diagnosis of acute pancreatitis requires 2 of the 3 features. It's typically abdominal pain, classic of pancreatitis, so upper or epigastric, that may or may not radiate to the back. Your lipase and amylase that are 2 to 3 times out of the normal limit, and you will have imaging findings that are suggestive of SANE. Typically not MRI, but usually if on the ultrasound or a CT, if done, we would find imaging findings suggestive of SANE. So again, we complete our checklist, making sure our history, physical, blood investigations are complete. And as we know, pancreatitis, these patients require large volume resuscitation, as resuscitation usually is the gold standard of treatment in these patients. So it's important to initiate the resuscitation in these patients prior to referral. And it's important to note that antibiotics are not standard once diagnosing the patient with acute pancreatitis. That elevated white cell count is usually all inflammatory. Only if we have confirmation of complications such as pancreatic, necrotizing pancreatitis or infective pancreatic necrosis is the only time that we would initiate antibiotics for these patients. And of course, if they're not resolving within the normal timeline. And again, when to refer or consult, as soon as that checklist is complete and you have made your diagnosis of acute pancreatitis. Our next cause of acute abdomen is the patient who presents with the perforated peptic ulcer. And we know an ulcer is a loss of, peptic ulcer is a loss of mucosal lining within the gastrointestinal tract, and perforation usually results following complete penetration of the wall of gastrointestinal viscus, whether it be stomach, duodenum, even within the intestines, but typically the former two. And who gets it? Usually the elderly lady who is self-medicating for her arthritic pain with NSAIDs, chronic use of NSAIDs or heavy use of NSAIDs within a short time frame, or the middle-aged gentleman with the chronic history of smoking, whether that be tobacco or cannabis smoking. This usually are two typical demographic of patients who present to hospital with a perforated peptic ulcer. It's important in our history, we inquire about symptomatology of nausea, vomiting, epigastric pain that may be progressed to generalized abdominal pain. That is the telltale of perforation and generalized peritonitis. We want to inquire about known medical problems such as gastroesophageal reflux disease or known peptic ulcer disease. And of course, there are social habits such as chronic tobacco or cannabis misuse. Patients can also present with change in bowel habits, and it's usually with perforation that causes an ileus in these patients. So you may also have that extreme or outlier patient who presents with bowel obstruction because of the perforation and the ileus that develops. I will always repeat it, start with assessing the patient's vitals and their general appearance when they present to assess or risk stratify this patient based on severity of disease. Examination findings may elicit epigastric or central abdominal tenderness. They may have abdominal distension because of the perforation and the free air within the peritoneum. And it's important typically in those who the smoker, who is usually that very thin male, sometimes it may not be always obvious of the distension, but if you cannot see their costal margin clearly, they're usually distended. So even though they are thin and you may think their abdomen is flat, if you cannot clearly see their costal margin, that usually signifies their distension there. They may have a rigid abdomen, generalized peritonitis on examination. Again, respiratory examination is important in most of these patients as they may present with extreme pleural effusions or aspiration pneumonia, particularly in the elderly persons because of the vomiting episodes. And so we want to make sure that their lungs are always clear and that we don't need to implement additional oxygen delivery methods or intubation for these patients. So the investigations for patients with perforated peptic ulcer are very simple. Your baseline complete blood count, electrolyte panel, an erect chest x-ray is important to identify that pneumoperitoneum. Very rarely is a CT abdomen warranted. There may be a subset of patients who may present delayed or with a concealed perforation that may not be obvious on the erect chest x-ray. And of course, with your suspicion, then you may proceed to a CT abdomen that then may show the area of perforation. So only in your outlier patients, typically do we get a CT abdomen for suspicion of perforated peptic ulcer. And this image here on the left shows your pneumoperitoneum under the right hemidiaphragm. And it's important that we look under the right opposed to the left, not to be confused with the gastric bubble or the appearance of overlying bowel that may sometimes mimic a pneumoperitoneum. And on the right, we see the CT evidence of the same. So again, our checklists, completing our history, physical exam, lab investigations, and that erect chest x-ray. And of course, because that patient is perforated, we always initiate our resuscitation for these patients. We typically administer antibiotics to cover H. pylori for patients who usually present with with esophageal reflux or known peptic ulcer disease. So that's usually the typical antibiotic that we administer or give for these patients prior to embarking on surgical intervention. And again, once the checklist is complete, please refer these patients immediately so that surgical intervention can be done for them. The next differential is acute diverticulitis. And acute diverticulitis is the inflammation and/or infection of a diverticulum, or an outpouching of the intestinal wall. And who gets it? So international literature states that it usually affects the Western hemisphere of the world. And typically the older patients who are obese, patients who have a low fiber or high fat diet, smokers, patients who use NSAIDs, opioids, and steroids. And why these patients or why these risk factors is because lifestyle, the low fiber, high fat diet, use of NSAIDs, steroids, and opioids alter the structure and motility of the intestine. So patients who are on opioids, of course, like they get a slower transit time, the feces stays within the colon, they have constipation, there's increased intraluminal pressure, the same thing with low fiber. And that causes outpouching at the weakened area where the blood supply to the colon, or the weakest area where the blood is diverticuli to develop. And of course, once that lumen becomes obstructed, similar to the previous diagnoses, that obstruction can set off that cascade of increased intraluminal pressure, edema, ischemia, and perforation in cases. Genetics has also been implicated, as well as alteration of the microbiome based on medication and even dietary changes. And so it's important that we stress or reiterate to these patients a healthy diet in terms of high fat, minimal red meat diet for these patients. So patients typically present with a history of chronic constipation, often having to strain or use medications or home remedies to have a bowel movement. They may present with left lower quadrant pain because of the constant straining or constipation. They may present with PR bleed because of hemorrhoids or anal fissures or tears. In the extreme cases where they present with bowel obstruction, they may also present with nausea or vomiting, or even because of perforation. And fever and chills we must inquire about. And the patient, of course, who may have generalized abdominal pain would indicate to us that this would be a case of perforated diverticulitis. Again, always assess the patient's vital and the general appearance so that we can have an idea of how ill this patient is and how urgently they need to be referred. Examination findings may elicit left lower quadrant abdominal tenderness. The patient may be distended, either because of perforation or presenting as a bowel obstruction, and they may or may not have generalized peritonitis because of perforation. Our investigations that we should complete our baseline complete blood count, electrolyte panel, and erect chest x-ray, yes, to rule out the presence of a pneumoperitoneum. And in patients with diverticulitis, we like to get a CT abdomen so that we can determine in terms of where this patient falls in the spectrum of uncomplicated versus complicated diverticulitis, in terms of how we treat these patients. So there is the Hinchey or modified Hinchey classification that we use to classify patients with diverticulitis, the complicated version, uncomplicated and complicated. And typically we, in terms of who needs surgical intervention, is usually those with stage 3 and 4. spectrum of disease who may present with generalized purulent or feculent peritonitis. The former two usually can be treated with antibiotics alone or may require percutaneous drainage. So this slide here just shows starting with your pericolic inflammation or collection, your pelvic collection, and 2, 3, your purulent peritonitis, and 4, your feculent peritonitis. And as I mentioned, the latter 2 usually require emergent surgical intervention. And so we complete our checklist, our history, our physical blood lab investigations, our CT, so we can differentiate whether they're uncomplicated or complicated in terms of who needs to have emergent surgical intervention. And of course, we initiate resuscitation and IV antibiotics for these patients. Typically, gram-negative and anaerobic coverage is sufficient for these patients in initiating. And in those patients who may present with bowel obstruction, it's important to have a nasogastric tube inserted to help in the decompression and symptomatology for these patients. And once a checklist is complete, we immediately refer these patients to the surgeon. The final, I believe, diagnosis in our acute abdomen spectrum for this morning is bowel obstruction. And bowel obstruction, textbook describes as a loss of normal aboral movement of contents within the gastrointestinal tract. So things simply are not moving in the normal direction as they usually should or as they should. And who gets it? It's simple as ABC. Yes, this is typical for patients with small bowel, but also can be large bowel obstruction. Typically, the female would present with adhesions because of previous abdominal or pelvic, namely gynecologic procedures, either a C-section, myomectomy, ectopic, or whatnot. You'll have the male who presents with the hernia, the incarcerated hernia, who presents with bowel obstruction. And then you have the elderly with the virgin abdomen who typically present with malignancy causing obstruction or in the form of obstruction. So it's important in our history to ascertain the cardinal signs and symptomatology, of bowel obstruction, including abdominal pain, if they've noted their abdomen becoming distended, whether they're vomiting, and any change in their bowel habits. It's also important in the elderly population, and as we're seeing now, more younger persons who may present with malignancy, to inquire about constitutional symptoms of weight loss, whether or not they may have any bleeding per rectum, symptoms of anemia, malaise, or easy fatigability, which are usually red flags that indicate that this can be a malignant cause of bowel obstruction. Again, examination always start with the vitals and the general appearance of the patient. Examination findings may elicit central or generalized abdominal pain, of course, abdominal distension. And with patients with bowel obstruction, as we mentioned, we always need a nasogastric tube inserted to help with the decompression and also to help us determine what type of obstruction this is based on what's coming out, whether it's gastric, enteric, or feculent contents, as that also indicates to us how we as surgeons manage these patients, if they can be managed non-operatively or if this is someone who warrants an urgent surgical intervention. It's always important that we examine to make sure that there are no masses present that may suggest malignancy, usually a right lower quadrant mass in persons presenting with right colon cancer, or a mass on rectal examination for patients who may present with rectal or left-sided colon cancer. So it's always important that we complete our examination with a digital rectal exam. Investigations, again, the complete blood count, electrolyte panel, as they speak to presence of either ischemia and our resuscitative efforts that are needed for patients with bowel obstruction, as these patients, similar to pancreatitis require large volumes for resuscitation because of the insensible losses from the obstruction and the episodes of vomiting. We must have erect and supine abdominal x-rays for these patients to make our diagnosis. And there are cases where CT abdomen may be warranted, but usually with the x-rays, that is sufficient for us to make the diagnosis of an acute of bowel obstruction. The CT we usually order after to try and determine what is the cause of obstruction in terms of how we manage these patients, if we can manage them non-operatively or if they require urgent surgical intervention. So this slide here shows the classic erect and supine findings of small bowel obstruction, multiple levels of air fluid levels centrally, and we have some peripheral bowel dilation. You see the plicae circularis on the supine film suggesting small bowel obstruction. And it's always important that we look at these x-rays, seeing if there is air in the rectum that may indicate to us that this may be a complete obstruction, whether or not we may see some ground glass appearance that may indicate or signify free fluid or ascites that may be related to malignancy as well. When a CT is indicated, it has the typical findings of dilated loops of bowel, air fluid levels. And in cases when CT is indicated, we look for transition points, presence of transition points, or actual mechanical obstruction that may tell us that this patient cannot be managed non-operatively. And the transition point usually is indicated as a bird beak sign on an abrupt change to collapse from dilated to collapsed bowel. That usually is a patient who cannot be managed non-operatively. And on our imaging, we look for dilation that's significant, the 3-6-9 rule for small, large, and cecum respectively. So of course, if the diameters approach or exceed those, these are patients who are on the risk or on the verge of perforation and of course need urgent referral. So I think most of our emergency room or some of our emergency room colleagues may see the SHOs often going to get contrast and passing down the nasogastric tube for these patients. And this is based on the Bologna study for patients, particularly with adhesive small bowel obstruction, as we're trying to determine whether or not we can manage these patients non-operatively. And most times it's not as easy for us to get a CT abdomen. So our alternative is to have a water-soluble contrast X-ray series done for these patients, simply to determine if the contrast reaches the colon within a specific time frame, usually within 24 hours after admission. So usually if we see that contrast on subsequent x-rays reaching the colon, this is someone who more than likely can resolve on their own and without any surgical intervention. And the contrast itself also provides sort of an osmotic effect to help with a bowel movement per se. So if you see the SHOs doing that, that is why. That's what's is based on this study, just for us to determine if we can manage this patient non-operatively or not, and especially when we do have difficulties obtaining CT abdomens for these patients. So again, the checklist, the history, physical exam, lab investigations, erect and supine x-rays, initiate resuscitation and NGT decompression for these patients prior to their referral. And once that's done, or when that's being done, please refer these persons emergently for surgical review. That brings me to the end of my presentation. I thank you very much for your attention, and I welcome any questions and comments.
Thank you so much, Dr. Bodie, for a wonderful presentation. Very extensive, very comprehensive. You have definitely filled our cup and open our minds to the very common things that we should be looking out for should these patients present to us. The floor is now open for comments and or any questions for Dr. Bodie. So you can feel free to either put the message, comment, question in the chat, or you can go ahead and raise your hand so that you can relay your question and or comments. And while you are thinking about that, I want to remind you to kindly fill out the feedback survey and also ensure that the name that you are on the call with is the name that you are registered in with the Bahamas Medical Council. Any questions, comments? Well, Dr. Bodie, I know we still see a challenge with obesity here in the Bahamas, unfortunately. Have you found in your practice that there has been an increased number of patients presenting with acute cholecystitis?
I think we get probably one each call. Just last night, I took in a patient with acute cholecystitis. And as mentioned, usually the response is non-emergent, but we have to remember acute cholecystitis is separate from symptomatic cholelithiasis. Actually, there were two patients who presented, but yes, it's mainly because of dietary. And again, it was a classic history of having crab and rice and then some steam conch the night before. And then, of course, the patient presented with the acute abdomen. So even if, again, if the patient isn't obese, although most of our patients and our population, yes, we do have an obesity endemic. You may have the thin patient, but just the history of the high fat diet who presents. But definitely it's classic of the patient being on the obese side.
Okay, so we definitely have a lot more work to do from our end on the primary care side to ensure that we continue to encourage our patients to eat healthy, exercise, remain within the appropriate weight. We have a few comments and questions. Great presentation and breakdown of a big topic. Well done. That's from Dr. Nottage. And we also have a question and comment. Excellent presentation. Thank you. For those of us in private practice who suspect acute abdomen and patient is relatively stable, should we send for radiology or send directly to A&E?
Yes, so once the patient is stable, and we say it even in trauma, if they're stable, we image before we take straight to the operating room. So once they're stable, you can get your imaging for your objective confirmation of your diagnosis and then refer them thereafter.
Okay, thank you. Do we have any other questions or comments? Okay, it doesn't seem. Okay, we have a thank you, Dr. Bodie.
It was either crystal clear or very overwhelming.
I think you did an excellent job going through each of the possible pathology in the abdomen, and it definitely provided clarity as to how we should maneuver with the patient when they present to us, particularly in the outpatient setting. So I definitely appreciated the talk. We have a comment that it was NASA glass clear.
Thank you, Dr. Colley.
So if there are no further questions and or comments, again, I would like to extend a very hearty thank you, Dr. Bodie, for presenting this most timely topic. And I trust that all of my colleagues are now eager, excited, and ready to receive these patients and proceed the appropriate management course. Until next time, I thank you for your attendance and congratulations to you all. You have just leveled up on your knowledge. Until next time, have a wonderful day.